Good morning, everyone. Thank you so much for joining us on this Halloween morning to talk about Ebola virus disease. If you can advance to the next slide, Jack. I want to acknowledge that we are very fortunate that today's session on Ebola virus disease is being presented by the Regional Emerging Special Pathogen Treatment Center, or the RESPTC for Region 1, which is the New England region, as well as the Region 1 Disaster Health Response System. Both of these are funded programs from the United States Department of Health and Human Services Administration for Strategic Preparedness and Response, and are intended to help our healthcare and public health partners across New England better prepare for and respond to, if needed, suspect cases of patients with Ebola virus disease. We need to give the usual disclaimer, of course, that the content being presented is from those of us who are speaking personally and does not in any way imply the official policy or position of the United States government. All right, so I'm Paul Bittinger. I am the principal investigator for both the RESPTC and RDHRS here in New England, and I'm really thrilled to be joined by an extraordinary group of speakers. We have Dr. Katie Brown, who is the state epidemiologist for the Commonwealth of Massachusetts, as well as the state public health veterinarian. Dr. Larry Madoff, who is the medical director for the Bureau of Infectious Disease and Laboratory Sciences at Mass DPH. We have Dr. Caitlin Dugdale, who is an assistant professor of medicine and infectious disease specialist at Massachusetts General Hospital, and Sarah Perry, who is the healthcare preparedness coordinator for the state of Vermont. Really thrilled to have everyone speaking today. We're going to hope that there may be a little bit of time for questions. Please put your questions into the Q&A or the chat. We'll try and keep an eye on them, and hopefully if we have time at the end, we will answer a couple of them. If not, of course, let us know what future webinar topics might be helpful as you prepare for Ebola virus disease might be of use to you. So we'll dive right in. We're going to talk about the current situation in Uganda. That is the reason that of course, we're having this webinar is regrettably a worsening outbreak situation of EBD there. We're going to try and be pretty practical. This is really meant to be a webinar for the healthcare community, trying to apply the principles of identify, isolate, and inform in emergency departments, in urgent care settings, and primary care settings, and talk about really what this means in practice. It's been a while since 2014-15 when a lot of us really were talking a lot about Ebola virus disease and patients who might present to our setting. There is a significant Ugandan expatriate community here in the New England area, and I think it's really important for all of us to be as ready as we can be for anyone who might present with the right epidemiologic and clinical symptom risk factors. Again, we're really fortunate to be joined by our state colleagues, and we're going to talk about partnership with and the role of state epidemiologists in assessing patients and determining level of risk. The good news is just not just the fact that you've been to Uganda does not count as a sole risk factor, and really excited to hear Dr. Brown, Dr. Madoff talk more about that. And then we'll talk about public health preparedness and the continuum of care for patients with suspected EBD, people who are what we call a PUI, a person under investigation, and really glad to have Sarah Perry with us. So with that, we'll dive right in, and I believe I will turn it over to Dr. Dugdale.
Thanks very much. So again, my name is Caitlin Dugdale, and I'm an infectious disease physician at Mass General Hospital. I'll be discussing Ebola virus disease updates and initial evaluation. So first, I think it's important for us to review Ebola virus disease epidemiology and clinical manifestations to make sure that we're all on the same page. So Ebola virus disease, sometimes abbreviated as EVD, is believed to be a zoonotic disease with a bat reservoir. And Ebola virus disease in humans may actually be caused by 4 different viruses within the genus Ebola virus. Most commonly either Ebola virus species Zaire Ebola virus or Sudan virus species Sudan Ebola virus. Ebola virus is the more common of the two and has been responsible for recent outbreaks in the DRC and in West Africa. And Ebola virus carries a 70 to 90% case fatality rate if untreated. We do have a licensed vaccine for Ebola virus that goes by the brand name Ervebo. While Sudan virus is less common than Ebola virus, it has been implicated in recent outbreaks in Sudan and in Uganda, last in 2012. And this virus carries an approximate 50% case fatality rate. Unfortunately, there is currently no approved vaccine for Sudan virus, though there are several investigational candidates. Next slide. Ebola virus disease is transmitted through broken skin or mucous membrane contact with the body fluids of a person who is symptomatic or who has died from Ebola virus disease. And Ebola virus has been isolated from virtually every body fluid, including blood, feces, vomit, urine, tears and saliva, breast milk, amniotic fluid, vaginal secretions, sweat, and semen. So while airborne transmission has not been documented, healthcare workers should take precautions to limit generating aerosols and ensure appropriate PPE use to prevent this possibility. Next slide. In terms of clinical manifestation, the Ebola virus disease incubation period is 2 to 21 days, though usually is 4 to 17 days in duration. And during this period prior to symptom onset, individuals are not believed to be infectious. Next slide. Once symptoms develop, individuals are thought to be able to transmit Ebola virus. And symptoms typically begin with what we call dry symptoms, including things like fever, headache, fatigue, muscle aches and joint pains, sore throat, and anorexia. Around 4 to 5 days after symptoms, individuals may develop a diffuse maculopapular rash or abdominal pain, and they may progress to what are called wet symptoms, including vomiting or diarrhea, conjunctivitis, or unexplained bleeding and bruising. And while we think of unexplained bleeding and bruising as being kind of one of the hallmarks of viral hemorrhagic fevers and Ebola virus disease, it's actually present in less than half of cases. So it's just important to maintain a high index of suspicion for Ebola virus disease in the context of the other symptoms on this list. Next slide. In fatal cases, death usually occurs around 7 to 10 days after symptom onset, and individuals are also maximally infectious at that time, which explains in part why Ebola virus disease transmission has been associated with funeral rites in some settings. Next slide. So turning to the Ebola virus disease outbreak in Uganda this year, on September 20th, the Ministry of Health of Uganda declared an Ebola virus disease outbreak caused by Sudan virus, which you may remember is less common than Ebola virus, but unfortunately we don't yet have a licensed vaccine for. As of October 24th, there were cases detected in 7 districts, including at least 14 cases in the capital of Kampala. The most of those were contacts of a man who had traveled from another district. And the outbreak thus far appears to be contained to primarily the western and central regions of Uganda. Of note, while individuals were undergoing testing for Ebola virus disease, there were at least 3 cases of Crimean Congo hemorrhagic fever also identified among people who presented with symptoms of Ebola virus disease, but who tested negative. And as of yesterday, current totals stand at 128 confirmed cases, 34 deaths, and a case fatality rate among those who are confirmed of 27%. Next slide. So while there is a low overall risk of regional and global spread of Ebola virus disease per the World Health Organization, preparedness remains key. So in Uganda, there are ongoing contact tracing and outbreak response efforts in coordination with the Ministry of Health and the CDC. And here I think it's important to acknowledge that Uganda is a country that's very experienced in dealing with Ebola virus outbreaks. And they report that approximately 98% of individuals who are identified contacts of cases of Ebola virus disease are actually in follow-up. That said, it's important that all of us maintain a high level of suspicion for Ebola virus disease, particularly in travelers returning from Uganda. And while there are no direct flights from Uganda to the United States, there are approximately 145 passengers who arrive in the United States from Uganda every day. In coordination with the CDC and public health departments, travelers are being redirected to one of 5 airports in the United States for additional screening. And those airports, as listed on the left, include New York City's JFK Airport, Newark Liberty, Chicago O'Hare, Washington Dulles, and Atlanta. So returning travelers are being followed remotely for 21 days after their arrival by our public health colleagues. Next slide. So now we'll turn to the 3 I's of identify, isolate, and inform. And this is a framework that was developed by the CDC in 2014 in response to an evolving Ebola epidemic at that time to help guide clinicians in the assessment of individuals with potential risks for Ebola virus disease. So identify speaks to the importance of identifying both a travel and exposure history as well as potential signs and symptoms of Ebola virus disease. So for travel or exposure history, we may ask, has the patient had contact with an individual with confirmed Ebola virus disease or traveled to a country with widespread Ebola virus transmission within the previous 21 days? And if the patient has traveled to a country with ongoing Ebola virus transmission, which currently includes the DRC and Uganda, we should also be encouraged to ask about specific cities or districts that they visited. For example, in Uganda, again, the outbreak appears to be most prevalent in the western and central regions of the country. So knowing where in-country individuals have traveled may help to tailor our pretest probability of disease. We should also be encouraged to ask for the exact dates of travel to ensure that the patient's symptoms began within the 21-day incubation period for Ebola virus disease. In terms of signs and symptoms, we may ask, does the patient have any Ebola-compatible symptoms, including fever, fatigue, headache, muscle aches, vomiting, diarrhea, or hemorrhage? And you'll note that Ebola virus disease symptomatology has considerable overlap with malaria, which is far more common in returning travelers than is Ebola virus disease. So we encourage providers to also inquire about the use of and adherence to malaria prophylaxis during their recent travel. Next slide. The next I is isolate. If the patient is in a clinical care setting and is identified to have a travel or exposure history and symptoms potentially compatible with Ebola, isolate the patient immediately. So providers are encouraged to place the patient in a private room, preferably enclosed with a private bathroom or covered commode, and ensure that they are wearing a facility-issued face mask. Providers should avoid unnecessary direct contact, including phlebotomy or other procedures not required for urgent stabilization, and should minimize personnel in the patient's room as appropriate. If available, providers could employ remote monitoring and communication devices, including phones, to evaluate the patient and conduct a further history. If direct patient contact is necessary, healthcare providers should use appropriate PPE, and full instructions about PPE donning and doffing are available at the CDC website, which you can access using the QR code at the bottom right of the screen. This PPE includes a fluid-resistant gown extending to at least the mid-calf, a full face shield, a fit-tested N95 respirator if the patient is unstable, vomiting, bleeding, or has diarrhea, and otherwise a medical face mask can be worn, and 2 pairs of gloves, the outer pair of which should have extended cuffs. Next slide. If the patient alternatively is identified by phone or during a televisit to have a travel or exposure history and symptoms potentially compatible with Ebola virus disease, please advise them to remain in place and to call their local health department. So providers should advise the patient to minimize exposure of body fluids to others near them, and the ambulatory care facility or clinician should inform the local health department directly. If the clinical situation is an emergency, the ambulatory care facility or the patient should call 911 and tell EMS personnel the Ebola risk factors of the patient so that EMS personnel can arrive at the scene with appropriate PPE in hand. Next slide. And lastly, inform. After a patient with a travel or exposure history and symptoms potentially compatible with Ebola virus disease has been isolated, providers should inform the relevant health department immediately, as well as their local facilities' points of contact. The local health department will provide guidance regarding whether or not the patient should be considered a PUI, and if they are a PUI, instructions for proceeding with testing for Ebola. And if the patient is determined by public health authorities to be a high-risk PUI, they may coordinate transfer to a different facility, such as an assessment hospital, an Ebola treatment center, or the Regional Special Pathogens Treatment Center, which for Region 1 is Massachusetts General Hospital. Next slide. In discussion with relevant health departments, additional diagnostics may also be advised for further workup of illness in a returning traveler while the patient remains a person under investigation for Ebola virus disease. And here it's just important to acknowledge that for most individuals returning from travel in settings where Ebola virus there's ongoing Ebola virus transmission, there will be many other conditions that are much higher on the differential than Ebola virus disease. And so ongoing assessment for these other illnesses is also very important. And top of that list, again, remains malaria. However, providers should also maintain index of suspicion for COVID-19 or influenza, enteric fever or traveler's diarrhea, typhoid, dengue, chikungunya, or Zika virus, viral hepatitis, or infections not necessarily related to travel at all, including things like urinary tract infections, pneumonia, or bloodstream infections. Next slide. While undergoing investigation as a PUI for Ebola virus disease, it may be challenging to obtain or contraindicated to obtain some of the diagnostics needed to evaluate the conditions on the left. However, there are a number of point of care tests and other investigations that may be feasible and prioritized for individuals who are EVD PUIs. So on the list on the right, I would emphasize the importance of a point of care rapid malaria test where it's available. So the Binax Now test is available in many settings. If it's not available at your center, you could consider pursuing thick and thin smears for malaria. And there's more complete instructions about malaria diagnosis among EVD PUIs available at the CDC website using the QR code on the right. Where available, point of care basic chemistries and point of care COVID-19 and influenza could also be pursued. And in discussion with public health authorities, providers may be encouraged to proceed with Ebola virus disease specimen collection at the time of their initial evaluation. Once an individual is no longer actively under investigation for Ebola virus disease, there are a number of other diagnostics that should also be considered and prioritized in the workup of illness in a returning traveler. And those diagnostics may include things like a urinalysis, urine cultures and blood cultures, viral hepatitis serologies, stool culture and parasite examination, chest X-ray, or other serologies based on exposure history and symptomatology. Next slide. So with that, I'll go ahead and turn it over to our public health colleagues. Thank you.
So thank you very much, Dr. Dugdale. Before we go ahead, if I may, there's one question in the chat for you about whether you know what % of patients have cytokine storm as part of their Ebola diagnosis.
I'm sorry, I don't know off the top of my head what proportion might have that. It's a really interesting question, but I don't know.
And the other actually, I think is maybe also for you and for our public health colleagues who are about to follow, but does a diagnosis of malaria in a patient with a pertinent travel history rule out Ebola? So if we get that alternative diagnosis.
I wouldn't say that it rules out Ebola virus disease, but it should potentially lower your pretest probability for Ebola virus disease. Obviously, you can have co-infection in many of these settings where both are endemic or circulating. But it helps to evaluate kind of to stratify overall assessment and level of risk for Ebola virus disease to have an alternative diagnosis in hand.
Perfect. I think that's really helpful. And then that'll certainly be the right pivot for us to discuss shared decision making with state epidemiology as we look at the real pretest probability, the exposure history, and the alternative diagnosis that we have, which often lets us progress. I do see that Dr. Levin has a question about processing blood samples, and I'll say a bit of a word right now, and then we'll come back to this. But one of the points I do want to emphasize from Dr. Dugdale's talk is how important it is that we don't miss the opportunity to intervene when a patient has a treatable illness because we're worried about EBD as a possibility. You're probably all aware that from CDC's morbidity mortality weekly report, they unfortunately describe a number of cases of poor outcomes back in 2014-15 because someone was worried about EBD and the patient did not receive the right antibiotics or the right antimalarials in a timely fashion. And that's a lot of what we're trying to talk about today, is how to make sure we keep our providers, our clinicians safe, but we also make sure that we're treating the patient. And so to Dr. Levin's question, we'll speak a little bit more about it. It's I believe, Dr. Dugdale, I want to speak for you, but part of why you're emphasizing the point of care testing is that I think there's a lot of concern about processing PUI samples on the large scale, high throughput lab equipment in the commercial labs, but point of care tests, especially, an iStat or a Binax that can be managed in a controlled environment in the patient's room is much, much safer to do when you have the right procedures in place. So let me turn it over now to Dr. Katie Brown. I'm really excited, and the segue here I think is going to work out really well.
Great. Thank you so much, Paul. Really appreciate the opportunity to be here. And my colleague and I, Dr. Madoff, want to talk about the traveler monitoring process. We want to talk about that just a little bit more. We want to talk about the risk assessment process that these travelers go through that should be helpful in informing the kind of response at the healthcare facility should a traveler develop a febrile illness that needs to be evaluated. We can talk a little bit about laboratory testing for Ebola virus disease, and then some of the expectations that we have of frontline hospitals for working with us to help manage, again, febrile travelers. So let's go to the first slide. So this current traveler monitoring process that Dr. Dugdale actually referred to was developed back during the 2014 large Ebola virus disease outbreak in Western Africa, and has actually been used multiple times since then, most recently in 2021 during a relatively small outbreak that was occurring. I will be honest that I completely don't remember that because we were also embroiled in COVID. But again, this is kind of a well-developed process that has been used multiple times. So the process involves a pre-departure screening in Uganda for exposure and symptoms of Ebola virus disease, and individuals who are identified as having a high-risk exposure are actually not allowed to travel. Travelers who meet the screening criteria, so they're asymptomatic and no high-risk exposures, are funneled into 5 airports in the United States. They're listed here again, just for your reference. And passenger contact information is collected by the CDC's Department of Global Migration and Quarantine, and that information is then sent to state health departments. The recommendation from CDC is that public health should take that contact information and follow up individually with the travelers. In Massachusetts, that follow-up may be done either by the State Department of Public Health, by Boston Public Health Commission, or one of the other local health departments. In New England, in other New England states, because public health is generally pretty centralized, that follow-up is largely being done by state health departments, but perhaps not exclusively. And that public health follow-up consists of a risk assessment. So again, we're kind of verifying the screening that this traveler already went through in Uganda. We're doing a symptom check. We're doing education with the traveler about the symptoms to watch for, the fact that they need to self-isolate if they develop any of those symptoms, and that they should then call public health. Another component of that education is that if they have an urgent need for medical care and they need to call 911, that they should make sure that they inform the EMS about the fact that they were a traveler. And then after this kind of initial risk assessment, symptom check, and education, there are repeat check-ins at a cadence that's determined based on that risk assessment. Next slide. So I want to talk about what are considered high risk exposures. And there's a couple of reasons for this, right? So these are individuals who have a reported known exposure to someone with Ebola virus disease, or, suspect Ebola virus disease. So I know Dr. Dugdale mentioned some of this, but it bears repeating. And I found a slide from 2014, which essentially said, you can't have Ebola virus disease if you don't know someone with Ebola virus disease. And so these high risk exposures really are based on that, right? So a percutaneous mucous membrane or direct skin contact with blood or body fluids of a person with known or suspected EVD, just direct contact with a person who has known or suspected EVD, living in the same household as a person with symptomatic known or suspected EVD. Sorry, I jumped around a little bit there. Providing health care to a patient with known or suspected EVD without the use of recommended PPE, or if there's a breach in the infection control precautions that results in an exposure, and then direct contact with or the occurrence of a breach in infection control precautions while handling a dead body in a Ebola outbreak area. If the body is of a person who died of Ebola virus disease or had an illness compatible with EVD. So, this is actually a relatively small group of people. And as we heard, the Ugandan Ministry of Health is actually doing a very good job at contact tracing in Uganda, and feels that they have been able to identify and follow up with about 98% of close contacts. So the likelihood that somebody who has one of these high-risk exposures showing up in the United States is low at this point. But it's really important to know what those high-risk exposures are so that you can bucket people when you're talking to them either into someone who has one of these high-risk exposures or does not. The one other thing I want to say is that the definition for a person under investigation on the CDC website currently is somebody who has one of these high-risk exposures and has symptoms that are compatible with EVD. So I just want to be clear that unless someone has one of these high-risk exposures, they don't actually meet criteria to be a PUI, even if they were a traveler to Uganda and develop a febrile illness. Okay, so that's really important. I will also say that depending on the way the outbreak evolves, that PUI definition could change, right? As of right now, because the outbreak remains small and it's felt to be relatively, the contacts are being identified and followed, we are able to kind of have this bright white line that says high risk exposure and fever, you can be a PUI. No high risk exposure, you are not a PUI. So again, for the moment, that's where it is, but we need to monitor, and that definition could evolve over time. Next slide. So just so you're aware, this is kind of the three buckets that we have of people following a risk assessment. So a reported high risk exposure, those individuals should be doing symptom monitoring daily. Public health should be checking in with them daily. There are movement restrictions on that individual. Should we have someone like this in the US, they would be under quarantine and would not be permitted to travel. People who were in one of those designated outbreak areas, should symptom monitor at least twice weekly for the 21 days following their, the last time they were in the country. And they are not under quarantine and are allowed to travel, but should do it in coordination with the health department. And then individuals who were present in Uganda but were not present in one of the designated outbreak areas are followed once weekly, just a check-in to make sure that they have not developed symptoms. And again, all of these individuals receive that initial risk assessment and the health education, what they should be watching for and what they should do if they develop symptoms. Next slide. So the real reason to do the traveler monitoring is not because we think that it is highly likely that any random Ugandan traveler without a known exposure to Ebola virus disease is going to end up in our hospital with Ebola, but is really so that we can manage them in conjunction with you all if one of them develops disease. Okay, so really when we're talking with them, we tell them if you develop symptoms, the first thing you should do, unless it's a medical emergency and you need to call 911, is please call public health, right? Call the person that you've been working with in terms of monitoring. Public health will reconfirm the exposure assessment, make sure that nothing was missed, that the traveler doesn't have additional information about, contact with EVD. Public health will ask for a description of signs and symptoms, will ask about malaria prophylaxis if they haven't already, and then we'll call the appropriate healthcare facility to prepare them for the patient. This type of warm handoff can really jumpstart that identify, isolate, and inform process. It can lower the temperature level in the room, the stress level of everybody who's involved in this. And hopefully the patient will be well enough to be able to transport themselves in a private vehicle. If that is not possible, the warm handoff can also include arranging for EMS transport if that is medically appropriate. So this is really what we're aiming for with this traveler monitoring process, is the ability to do this warm handoff. Scenario 2 is that the traveler develops symptoms and just ends up at the healthcare facility without that warm handoff, in which case the burden of identifying is really on the healthcare facility. But again, scenario 1 is what we're all working towards. Next slide. So I'm going to turn this over to my colleague, Dr. Madoff.
Thanks, Katie. Thanks, Paul and Caitlin. And I'll be very brief here, honestly. This is, I'm going to walk through, what we expect would happen at the healthcare facility once a patient arrives under these circumstances. And Caitlin has already touched on some of this, but I just think it's important that we step back for a minute and remember that we have a patient in front of us and that we need to look at the patient, evaluate the patient. We isolate them as appropriate. We provide emergency care as needed. And just because somebody has some risk of Ebola virus disease, does not mean that we don't provide them with the level of care that any patient would expect. We need to consider possible diagnoses, which may include Ebola virus disease, but as we've alluded to, may include many other diseases. This is a good time to call the health department, and I've listed our Mass DPH 24/7 number. You can call this number any time of day or night and get a call back promptly from one of our epidemiologists, who in turn can be in contact with us and also can walk through the scenario with the providers. Based on the epidemiologic risk information and symptom information, we would discuss with you whether testing for Ebola virus disease is indicated. This is a decision that's made in consultation between the providers and public health. And so this is a really important point of contact with public health. Obviously, again, we don't want to prevent or delay appropriate medical care to the patient. Very often, if somebody has signs and symptoms compatible with Ebola virus disease, they also have signs and symptoms compatible with sepsis, with malaria, and even with COVID or influenza, as Caitlin's alluded to earlier. And so in this setting, those tests are normally indicated. It is true that these findings can be present with Ebola virus disease, but I think that if one of these syndromes is present, it lowers the likelihood that one of these diagnoses is present. It lowers the likelihood of Ebola virus. Next slide. So when we're discussing the need for Ebola virus testing, we need to already know the specific location of travel and the dates. And we've all seen scenarios where someone has traveled to another country that has just been misidentified, where the travel precedes the outbreak of Ebola, or when the travel is way outside of the incubation period for Ebola. And so this again can lower the stress in the room, and obviously does not mandate testing for Ebola. Is there a known contact with a person or a body with Ebola or suspect Ebola? And again, you don't get Ebola without such contact. Does the person work in a healthcare or laboratory setting in an area with Ebola? We need to be able to discuss with you the signs and symptoms and the timeline. Knowing whether someone took malaria prophylaxis, again, informs our risk calculation. We've all seen cases where malaria can develop even in the setting of appropriate prophylaxis, but it's unusual, and I think it would change our assessment of the situation. And finally, are there known exposure to other infectious diseases that can alter the risk calculation? So these are all things that we would want to discuss with the provider, involved in the discussion between the provider and public health authorities. Could I have the next slide? So testing for Ebola is available at the State Public Health Laboratory. Our laboratory here in Jamaica Plain has recently validated portions of the Warrior panel, and our lab is now able to detect all of the Ebola virus species, as well as Marburg virus, another hemorrhagic fever virus, and specifically does include the test for Ebola virus Sudan, the cause of the current Uganda outbreak. And so this is new. This is something that we did not have even a few weeks ago, but it is now available now. And the testing can be arranged anytime. In terms of the laboratory that is required for this, in terms of specimens, we need 2 tubes of whole blood, a purple top tube, a plastic tube, please, that needs to be transported chilled but not frozen. And you don't need to do anything else with those tubes. They don't need to be aliquoted, opened, spun, or anything. We don't want heparinized tubes or glass tubes, as I mentioned. And then we will discuss with you, rather than go into the details of packaging and shipping and how to get the specimens to the state lab. That's a conversation that will occur in real time, and we will make it easy to get specimens to the state lab. We do, which is consistent with CDC guidelines, the Public Health Department recommends that facilities continue to provide routine testing of patient samples as long as strict adherence to proper PPE usage is followed. And that includes, the ability to do malaria smears if that's necessary. Although our hope is, and we're actually looking into this right now, what the availability of rapid testing is here in the state. We know that not every hospital has that available, but when it's available, it can be, it can save a lot of laboratory processing and so forth. Next slide. So again, and this is really a little bit repetitive, identify, isolate, inform, evaluate the patient, obtain the appropriate samples for diagnostic testing, and provide care for the patient pending Ebola virus test results when testing is indicated. Next slide. That's it for now, and we're around for questions.
Thank you so much, Larry and Katie. That really was fantastic. I think just a couple of questions I see here in the chat. There's a question about what % of return travelers are lost to follow-up by public health. Can you comment? Obviously, there's certainly challenges, especially as people move around states or regions within the U.S.
Yeah, one of the things I'll say is it's not a perfect system, right? But it is part of this kind of layered prevention strategy approach that we're doing in conjunction, right, with Uganda. And so the idea is that there is screening and evaluation in Uganda before the traveler ever gets here. There is collection of contact information for the traveler by both the airline and CDC. CDC is putting into place a process whereby they confirm that contact information with the traveler as the traveler is coming through the airport, and then that's passed on to the health department. What we're finding is that loss to follow-up is low, but it does occur, and individuals who are found to be, say, they came to Massachusetts and then ended up in Maine, we would go ahead and transfer that information to Maine. So again, there's a big public health process associated with this that is not perfect, but is good.
Excellent. Thank you so much. And then this is a question that could be probably most of the session itself, but I want to ask you to comment on your perspective on quarantine or furlough for people who are returned travelers who have no symptoms. Presumably there is no recommendation on anyone who has not had a known contact with an EVD patient or been working in an EVD area. But if there is a returning traveler who has been working in an Ebola treatment unit or has had exposure but protected exposure, there's been a lot of evolution in the last 5, 6, 7 years of this discussion topic, and I was wondering if I could just ask you to speak very briefly.
Yeah, so again, the definition of someone who could be a PUI is someone who's had a high risk exposure, which would be direct contact without PPE or a known breach in PPE, okay, plus symptoms. So someone who has that type of contact and has has that type of contact would be quarantined, okay? You know, the concern would be that represents a higher pretest probability of ending up with Ebola virus disease. And so we want to make sure that their movements are controlled and that we're, you know, able to monitor them closely and get them to care immediately should that be necessary. Individuals who do not have those types of exposures, so are, you know, have worked in an Ebola treatment unit, but used PPE without a known breach, would not meet that high risk exposure criteria. You know, I am not qualified to talk about what any individual employer might choose to do with that employee, but from a public health standpoint, those individuals would not be considered quarantined.
Perfect. And I think that's the really, really important point, right? Is again, it's back to the risk assessment, and it's about unidentified high risk exposure, really, which is guiding this. So I think that's really helpful.
And I think, Paul, I would just add that this is based on Ebola not being transmissible prior to the onset of symptoms. And, you know, that we've seen, we have a lot of experience now with this, and we know that Ebola is not transmitted by an asymptomatic individual. And so, you know, the quarantine is, you know, is a very cautious approach in these circumstances, and it isn't warranted when there hasn't been a high risk exposure.
Yeah, really good point. Two last questions, and then we're going to move on to our Vermont colleagues. The two sort of about lab equipment. I think it's, you know, there's a comment that lab POC, point of care equipment, is a challenge due to cost, understood. I think the 2 points I would emphasize are, one, that if a patient is really sick and needs urgent intervention for alternative diagnoses, again, bacterial sepsis, malaria, that the intervention to clinically support the patient with staff wearing the right PPE that can don and doff it safely has to occur. I think what we just don't ever want is the circumstance where someone has a treatable illness and due to an inability to initiate therapeutics that the patient has a bad outcome. So just really emphasizing that in the front line. And I think the question then is, when do patients get transferred, especially interstate across New England? And, you know, the system is set up for really confirmed cases to be transferred interstate. And so each individual state has to have its own mechanism for doing the diagnostic testing. I think if there's significant interest, and please feel free to email us about this, we can have another webinar maybe focused among state health departments and some of the laboratorians to talk about how we can make that happen as safely as possible. But that's really sort of one of the fundamental tenets of the national system, and certainly confirmed cases, again, at the discretion of the sending state health department, the receiving state health department in Massachusetts for MGH is where MGH would be the receiving facility. But we do have other Ebola treatment centers in the New England region that are capable of supporting care for a confirmed case as well. I want to speak briefly, just there's a great question about should we be screening in community hospitals, and my perspective is absolutely. I think this is more something we're trying to get into the background of what we do all the time, not just even when we have Ebola outbreaks, but that identify, isolate, and inform, that ability to have your clinicians in community hospital emergency departments and urgent care centers ask about a travel history, ask about a symptom history, and then know where to go, know who to ask if they have a question about whether that prompts the diagnosis is really, really important. Okay, we're going to move on to Sarah Perry from the Vermont Department of Health and talk about the role of public health. Thank you so much for joining us, Sarah.
Thank you, and good morning, everyone. As Paul mentioned, I work as the Healthcare Preparedness Coordinator at the Vermont Department of Health, and it's my pleasure to present today on public health preparedness in general and the continuum of care for patients with or suspected of having a high consequence infectious disease. Next slide. And yeah, we'll just start by looking at the role of public health preparedness in responding to high consequence infectious disease in Vermont. And by state statute, Vermont Department of Health is tasked with coordinating the planning, development, and implementation of a comprehensive emergency medical program in any warranted all hazards event. Next slide. And when considering a high consequence infectious disease event such as Ebola, it could be argued that the majority of the CDC's public health emergency preparedness capabilities apply. I started highlighting the ones that would apply, and it was pretty much all of them. Next slide. Several programs funded by Health and Human Services Administration for Strategic Preparedness and Response have guided Vermont's medical response planning, including the Hospital Preparedness Program, as well as the Regional Disaster Health Response System. Next slide. And as mentioned, there are potentially multiple public health responsibilities during a medical response. This slide is just an attempt to list some, and really the role is to advance preparation. Vermont Department of Health has been working to establish a medical response continuity of operations plan, which we are currently calling our Medical Operations Network, CONOPS. Next slide. Vermont's Medical Operations Network, or MON, is a network to improve communication and coordination of multiple agencies and healthcare entities during a response. So our vision is to have a single statewide hub for data-driven and stakeholder-informed decisions that can enhance and facilitate the coordination of medical resources and information during an event. The expectation really is that the MON will be a centralized communication coordination conduit for public health and healthcare partners to help bridge various emergency operations center during something like an Ebola event or transportation of an Ebola patient, perhaps. Next slide. So moving right along, I'm going to talk about an experience we had in Vermont practicing the continuum of care for an Ebola patient. And thanks to the collaboration of numerous stakeholders, a few years ago, we conducted this exercise, and it was basically exercising the continuum of care planning for patients with a high consequence infectious disease. And I'm going to share our primary lessons learned during the exercise and throughout this continuum of care. And I would be remiss if I didn't mention by name some of the heavy lifting and extensive contributions to this exercise that were made by Michelle Greason from UVM Medical Center's Health Network Critical Care Transport Team, and by David Casey, who was our Vermont Department of Health representative and the patient actor. And a special thank you is owed to Jonathan Thrall and crew for their incredible filming of the exercise. And thus I'm going to be able to show you some pictures from the exercise. Next slide. On June 18th and 19th of 2019, staff from the Vermont Department of Health, Massachusetts Department of Health, New Hampshire Department of Health and Human Services, University of Vermont Medical Center, Central Vermont Medical Center, and Massachusetts General Hospital and Dartmouth Hitchcock Medical Center organized and conducted a full-scale Ebola patient care and transport exercise. Many different organizations followed a detailed timeline to carry out the isolation care and transfer of care for a patient actor, requiring communication across multiple states, multiple hospitals, and multiple departments within these entities. A patient actor arrived at a frontline hospital describing symptoms of Ebola. The patient was transported from the frontline hospital to an assessment hospital, and then to the regional Ebola treatment center at Massachusetts General Hospital. And the objective of this exercise was to practice and evaluate the safe and effective care of a patient with a highly contagious and highly pathogenic disease, such as Ebola virus disease, while protecting the health and safety of medical providers and the public. We really gained valuable experience in caring for a patient with Ebola and identified several areas of strength and improvement. Next slide. One of the first lessons that came out of the exercise was that early disease identification ideally starts before the hospital, as mentioned in previous presentations, with public messaging, signs on doors, etc. But it's also critical to prepare at registration in a hospital, from taking patient histories to possible triage. Next slide. Several areas for improvement were also identified around early laboratory specimen collection and transport. And these are three specific lessons that came out of our exercise. Frontline hospitals may not have the training or expertise to collect and transport the laboratory specimens. Proper Department of Transportation packaging of specimens is required before shipment, and collection of 2 samples is best to accelerate further testing as appropriate. This was also already mentioned, but of course, real-time conversations will be part of addressing any issues, and the communication was key to all of this. Next slide. A third lesson learned was the importance of thinking through patient movement within a facility. And stretcher to bed, bed to stretcher transfers happen every day in hospitals without necessarily considering infection prevention. COVID has perhaps helped to advance some of the day-to-day practices when dealing with a highly infectious patient. And it's important to continue to think about the safest way to move such a patient through the hospital. Next slide. So mitigating contamination, I don't think anyone imagines it to be easy, and it really takes a team approach to prevent the spread of infectious disease in any healthcare setting. For example, some of the things that came up trying to move the patient through the hospital were who pushes the elevator button, And who's keeping track of the areas that are potentially being contaminated, and how are these areas identified or marked? Next slide. And last but not least, ambulance decontamination was a known issue of concern headed into the exercise, and it was proven to be a difficult challenge between the many exposed surfaces and the time required to adequately address decontamination. Next slide. Transport times can take hours. Folks can imagine with all the PPE, adding ambulance draping and decontamination time to a trip may result in high consequence infectious disease transport ambulance and crews being out of regular service for a day or more. You know, these conversations were had during the exercise. Nobody wants to ride back home in anything but a scrupulously clean ambulance. And it has been said that it might not be ideal to have tired ambulance crews who have just completed transport in full PPE have to decontaminate their ambulance at Mass General Hospital. So altogether, just to give you an idea, the transport from UVM Medical Center to Mass General Hospital on the second day of the exercise took approximately 12 hours round trip. So there were 6 hours transporting the patient from Burlington, Vermont to Boston, and 2 hours of doffing and donning, because they did stop at Dartmouth Hitchcock Medical Center to transfer out the crew, and then a 4-hour drive for the return. And the ultimate takeaway really was the importance of developing and exercising all of these plans with all the partners beforehand. I think everyone who was involved in this exercise agreed that it was extremely helpful and everyone learned a lot. Next slide. UVM Health Network made a short video of the exercise, so we could share that, but I see we have 4 minutes left, and I will pass it back to you, Paul, to decide if this is worthy of Q&A or a video.
I think it's good, Sarah. There's one question in the chat that we may take offline, but for Katie and Larry, about the current list of EBD treatment centers besides Mass General in Massachusetts, and we can follow up with folks offline, or I don't know if Katie, you want to mention that now. We may have lost. Oh, there you are. Yep.
Nope, sorry. Yeah, I think we can follow up offline, but you know, I do want to just re-emphasize that there really is a need. Someone who has traveled to Uganda and has a fever could actually end up almost in any facility. And we may not always have the opportunity to direct them to sort of a designated assessment or treatment facility. And we certainly don't expect MGH to have to see every febrile Ugandan traveler. And so just a reminder about the expectation that everybody should be able to manage the identify, isolate, and inform, and then we can work between the hospital and public health to make decisions about next steps. Awesome.
Thanks so much, Katie. And I think, you know, for those outside of Massachusetts and Vermont, as Sarah has just been going through, I think, again, from the regional center perspective, we're going to continue to be doing a lot of work with the state health departments, and we'd love to help support hospitals that are trying to develop additional capabilities just to support, identify, and inform as well. So Sarah, I think now is the perfect time. It's a nice video. Let's go ahead and show that, and then we will wrap up. But I want to thank everyone so much for attending today. I want to thank our speakers for some really great information. And this is really just a start. We're looking forward to continuing to work together to make sure these plans get refreshed and renewed and stay current as we move forward. So Jack, if I can ask you to tee up that video. Excellent. So thank you to Sarah. That was a Herculean lift by all of the Vermont staff, great collaboration with Massachusetts, with MGH and others. So thank you again to everyone for joining us. Please reach out with specific questions or thoughts about how we can be helpful, and about future trainings or webinars or other ways that we can pull the region together. So this is our contact information for the Regional Emerging Special Pathogen Treatment Center. BRT is Biothreats Response Team. Please reach out to us. Thank you again for joining. It's always good to connect.